Hi guys, welcome back to the channel. Today we are discussing the endovascular therapy for acute stroke with a large ischemic region. This is also landmark trial. This is a NEMG published trial. My name is Dr. Buddhabhushan Borade, MBA citizen. You can follow on my Instagram ID and you can follow or subscribe to my channel Medi Talk by Dr. Bhushan to get a new video and new chapter.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of some whatever. Under any circumstances, the author accept no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question for this study: in a patient with a large cerebral infarction volume, does use of endovascular therapy alongside with the medical care compared with the medical care alone improve 90-day functional outcomes? This is a second trial. This is endovascular treatment for acute stroke caused by the occlusion of large vessel has been proven by the highly effective treatment that reduce the death and disability. This has been proven in multiple trials. Mr. Clean, in further videos we can discuss. Dawn we already discussed. Extended also we discussed. Diffuse also discuss in our channel. You can follow in further videos and in previous videos. So prime aspect score is a semi-quantitative score to characterize the extent of middle cerebral artery MCS stroke. It ranges from the 10 to 0, where the 0 indicates the largest infarction burden. Previous trial have excluded more or limited number of those who have with a larger infarct volume due to the concern surrounding risk of bleeding following reperfusion. Systemic review looking at those with large infarct volume, accept ratio less than 6 or core volume more than 50 cc found no risk of increased hemorrhage and improved functional outcome with the use of EVT, endovascular treatment. Design for this study: open label, parallel group, RCT, central randomization, 1:1 ratio, assignment not concealed from patient to treating physician, train assessor for modified ranking score, blinded, clinical assessment performed by at baseline at 12 hours, 24 hours to 72 hours, 5 to 9 days and 60 to 120 days after randomization. Our calculation based on local registry data, which shows an over 3.4 in favor of EVT. Given this was observational registry data, authors assumed adjusted or 2.7. This required 81 in each arm, which was increased to 200 in total, allowed to 15% dropout withdrawal of consent. Primary analysis performed all of this randomization had accessible outcome data. Even adjustment assessing the MRS score used for randomization, imaging committees could be remove patient from trial if clinical or imaging parameters used for inclusion were not met or reviewed. Per protocol analysis performed on those not excluded. Pre-specified subgroup for the last time known value was added. The post hoc written informed consent provided prior to treatment or enrollment. Setting for the study is in Japan, 45 hospitals. Duration for the study was to November 2018 to September 2021. Population for the study: inclusion criteria: age more than 18 years old, NIHS score of at least 6, pre-modified morbid modified ranking score 0 to or 1, internal carotid or M1 segment of middle cerebral artery, occlusion of CT or MRA, aspect ratio score 3 to 5, within a 6 of last known well or within a 6 to 24 hours within a flared sequence of MRI, had to show recent infarct. EVT initiated within a 60 minutes following randomization. Exclusion criteria: clinical significant mass effect with midline shift, acute intracranial hemorrhage, pregnant or suspected pregnancy, evidence of chronic occlusion, investigator felt high risk of hemorrhage, judged to likely non-compliant or uncooperative, 235 assessed for eligibility, 203 randomized, 100 in EVT groups, excluded after adjunction, 94 per protocol, 102 in medical group, 8 excluded, 94 per protocol. Across both arms, 11 by 14 remove whereby expect score other than 3 to 5 or non-presence of ICA or AM1 occlusion. Comparing the baseline characteristics of EVT versus medical care group, generally similar although large infarct volume in medical care. Age 76 to 75, male 54 to 56, medical history hypertension 70 versus 68, AF atrial fibrillation 59.4 versus 50.8, systolic BP 156 versus 163, median modified ranking scores prior to 0 versus 0. Intervention, endovascular therapy and medical care. EVT method selected by treating physician could be include stent retriever aspiration catheter, balloon angioplasty, intracranial or carotid stent. 98% had a thrombectomy. Success defined as a TICI-2B integrated reperfusion more than 50% of previously occluded territory. Control group, medical care only. Management common to both groups. RTPA means recommended RTPA allowed to 0.6 mg per kg as per Japanese guidelines and discretion of treating. Then recombinant tissue plasminogen activator. Example like altiplase, tenecteplase and retiplase. In our Indian book, 0.95 mg per kg you can use. Medical care was as per AHA or American Stroke Guidelines. Outcome, primary outcome, modified ranking score 0 to 3 at 90 days, comparing versus EVT versus medical care 31 versus 12. Relative risk 2.4, AR absolute risk reduction 18, NNT 6. Secondary outcome, comparing with EVT versus medical group, no significant difference in modified ranking score 0 to 2 at 90 days, 14 versus 7.8. Modified ranking score 0 to or 1 90 days, 5 versus 2.9. Significantly greater in intervention group, ordinary shift on a modified ranking score towards the better outcome 2.48. Improvement in more than 8 points in NIHS score at 48 hours 31 versus 8.8. Safety outcomes, higher rates of intracranial hemorrhage within 48 hours 58 versus 31. Our rates of symptomatic ICS rate similar 9 versus 4.9. Other safety outcome include the death within a 90 days, recurrence of infection within a 90 days, decompressive craniotomy within a 7 days. We are all similar. Procedure complication rate 8.98%, 5% vessel perforation. Other serious adverse events 33.7 in EVT group compared with in 18.6. Result of the per protocol analysis was similar to the result described above. Strength for this ICU trial. A randomized trial answering the important clinical question in area of medicine that has been large evidence base for its use. Generally balanced baseline characteristics, analyze and intention to treat basis. All of those were the randomized only one patient EVT group, non-consent such as not include an analysis, no loss to follow up documented, no crossover the reported, trained and blinded assessor for primary outcome. The infarct volume was larger than in other trials. For infarct volume had to be less than 50 ml or diffuse 3 less than 70 ml. Median expert ratio was 9 in SWIFT prime trial. Weaknesses, single country setting may limit the external validity. 6 by 45 center had more than 10 participants and 20-50 had less than 3. This may be important with regards of lower volume center and complication rates. Modified ranking score rates only physical ability but no other QOL metric where the reported will not be doubt important to the patient. High rates of cognitive impairment have been demonstrated post-ischemic stroke. Slight but potential clinically important change in primary outcome compared to other comparator trials. Diffuse extended subprime, subprime, all used in modified ranking score 0 to 2 primary outcome. And a modified ranking score of 2 is slightly disabled, whereas 3 moderate disability with the requirement of some existence. There is no difference between groups of MRSA 0 to 90 days, although the accept score were higher in the medical group, but stroke volume was larger by 16 ml. Initial approach to imaging may not be consistent with other countries' initial radiological assessment of stroke in ED, like emergency department. High rates of MRI as opposed to CT determine the aspect ratio. MRI has been shown to be lower accept score compared with the CT. No use of perfusion imaging to guide treatment. This may help to better determine the salvageable tissue. Low rates of tenecteplase or recombinant tissue plasminogen activator use compared to other countries. Lower dose. Higher rates of tenecteplase may improve outcomes in medical care group. Funded by Mihara Cerebrovascular Disorder Research Promotion Fund and Japanese Society of Neuroendovascular Therapy, both non-profit and had no role in decision of conduct the trial. Author conclusion: among the patient in Japan with acute stroke and large ischemic region functional outcome at a 90 days were better with endovascular therapy and medical care compared with the medical care alone. Endovascular therapy was associated with a higher incidence of intracranial hemorrhage. Following this trial will be important to discuss use of EVT in large ischemic stroke. However, any decision will need to be made in multidisciplinary approach given some concern around the external generalizability. The higher rates of intracranial hemorrhage and serious adverse events alongside the fact of large number of patients still have significant disability. Thank you. Please subscribe to my channel.